Hi, I'm Kristen, and I'm an orofacial myofunctional therapist. And I get quite a few patients sent to me who are struggling with their sleep or concerned about their sleep. And so today we're going to talk about the structure of our skull and how that affects our sleep, and how the tongue and the space that it has and the mobility it has and the restrictions that it can have and how that affects sleep. So let's get started. So first of all, why is sleep so important? Sleep, as you may or may not know, affects so many things in our lives. If we are not getting good quality sleep and enough quantity sleep, then it's going to affect our memory, our ability to think and concentrate. Our mood will often fluctuate. We might be more prone to accidents, both in the car or otherwise. Our blood pressure often rises. Our immune system might get weak, or we'll be more at risk for diabetes or weight gain, or not be able to take the weight off when we want to. We may have a lower sex drive, may be at risk for heart disease, or even suffer from poor balance. A few things for parents to look into when it comes to sleep is, are their kids reporting nightmares or waking up with night terrors? Do they sleep with their mouth open and they're breathing through their mouth? Is their breathing audible at night? It shouldn't be. When we're sleeping, our breathing should be silent because we are at rest and we're not exerting ourselves in any way. Are they restless in bed? Are all of their sheets and pillows on the floor when they wake up most mornings? Are they wetting their bed even after they've been potty trained? Are they grinding their teeth or visibly clenching their teeth? Are they tired when they're waking up? Is their head angled back when they sleep? Now, this is kind of interesting. If you've ever taken a CPR class, you know that one of the first things you do after you check to make sure that the scene is safe is to look inside the mouth. And if there's nothing inside the mouth, then you tilt the head back a little bit. Why? Because it opens up the airway. And so if a child is struggling to sleep, they may reach their head back while they are sleeping or support their head with their hands, opening up that airway. Those are all signs that their airway might be closed off while they're sleeping and they're struggling to breathe. Anyway, let's go and talk about what we can do about it. Today, we're going to talk about tongue restrictions and how that affects the formation of our skull, specifically the face part of our skull, so like the front half of our skull. And that's important because the front half of our skull, especially this section from just below the eyes to the chin, is a lot of airway. The nose, the mouth is an emergency part of the airway, and then we've got the pharynx and the larynx that comes down from there. And the tongue is supposed to help us maintain that space. And so if it's not doing its job, then we need to do something about that. This is Dr. Ron, and he found in one of his studies that 5 hours of intermittent hypoxia can cause brain damage, killing Purkinje cells, which are responsible for motor coordination. Hypoxia means low oxygen in the tissues. If the body is not getting oxygen to its tissues, then we are going to start seeing brain damage just after 5 hours of this stuff. So if a person is experiencing a difficulty of breathing while sleeping night after night after night, there's a possibility they're going to see brain damage. In fact, another study showed that if a child snores by the age of 8 and is not treated, there is an 80% chance that the child will suffer 20% permanent reduction in mental capacity. So if your child is snoring, or you know of a child that is snoring, like you're the grandparent or the different kind of caregiver, please be aware that snoring is a sign of struggling to breathe. Snoring is literally air passing through the passages and hitting structures. Air makes noise when it hits something else, right? And so if it is hitting enlarged tonsils, enlarged adenoids, a deviated septum, nasal polyps, or the tongue is sitting back in the airway further than it should, the air is hitting those structures and it is creating a noise. Snoring is what that noise is. What can you do about it? If you think that you are struggling to sleep and you think that it might be your breathing, please get a sleep study. Talk to your dentist, talk to your general doctor, or go talk to a sleep dentist. They can all prescribe a sleep test, and this is really great because this is going to tell us if you're suffering from something called sleep apnea, which is the most severe form of an obstruction that's going on in the airway. This other really cool thing that I've got here on the screen is the Oura ring. It's something that a person can wear for months to years, and it will give you a sleep score. This is not the same thing as a sleep study. It does not, it's not considered accurate enough to be a sleep study, but it's going to let you know if you're getting some deep sleep, and it's pretty good at telling you what your heart rate is and your heart rate variability and your oxygen, and it can kind of tell based on your heart rate whether or not you're going into deep sleep or you're in REM sleep or light sleep. And there are actually several universities using the Oura ring on studies of their own, trying to decide how, or trying to use it to help them further understand sleep, which is really kind of cool. I have one myself. It has helped me with some of my sleep habits because it gives you ideas. It says, hey, you know, your heart rate didn't drop as soon as it should have after you fell asleep. Were you eating too late at night? Did you exercise really late at night? You stayed up way too late last night as compared to all the other nights that you were going to sleep. That can really throw off your sleep. It's best to keep the same bedtime and the same awake time if at all possible. All of these ideas it has for if it's seeing that you're not quite getting the right amount of sleep or a good quality of sleep. And when you do a good job, which this is really awesome, it'll say, hey, you have a great sleep score. Think back to right before you fell asleep. What were you doing that helped you improve your sleep score? Did you go through a meditation that helped you breathe better right before you sleep? Did you make sure not to eat, 3 hours before going to sleep? And so it kind of gives you a little pat on the back too, which is great. So it's immediate feedback, which is something I love because I used to not sleep well myself, and I just thought that that was normal. And it wasn't until I had one of these that I realized, oh, I'm not actually sleeping well, and that's why I'm groggy and sleepy during the day, and sometimes I'm cranky during the day. And if I've pick up some of these better habits, then I'm going to sleep better and I'm going to function better, and that means my life is going to be a little bit better too. So really kind of cool. This little kid, he was struggling with sleep quite a bit, breathing through his mouth. He had enlarged tonsils and adenoids. They were removed, and he continued to breathe through his mouth because no one told him to close his mouth and breathe through his nose. Everyone thought, hey, now he can sleep better. He's not snoring. His tonsils and adenoids are removed, but he was still breathing through his mouth because no one said, well, now you need to work on retraining yourself to breathe through your nose. And so his face actually started to grow long ways instead of forward and a little bit out this way. And so when the face grows long, that's a problem because the face will stay narrow. And the roof of the mouth, when it's narrow, well, the roof of the mouth is the same thing as the floor of the nose. And so when the roof of the mouth and the floor of the nose are quite narrow, that means there's not a whole lot of room for the tongue inside the mouth when it's staying closed. And that means that that tongue is going to get shoved back into the airway. It also means that the nose is going to be smaller, and so it's harder to breathe through the nose. And this is a bit of a vicious cycle because it's hard to breathe through the nose, and then you get allergies. Then the nose swells up, and then you have to breathe through your mouth. And then as the more and more you breathe through your mouth, the more the tongue isn't putting the pressure that it needs on the teeth, counteracting that pressure of the lips and the cheeks on the teeth the other way, and the face just continues to grow long ways instead of forward, opening up that airway. So anyway, his mom, super awesome, and she continued to talk to people, and she found an airway dentist and a myofunctional therapist, and together, they help to neuromuscularly retrain the tongue to sit where it needed to, and they got him some expansion of the palate to help him catch up for his age, and his face has been growing normally ever since because he now has the tools that he needs in order to do that. And we're going to talk a little bit about that. These two patients, we're going to call them Sam and Kelly. These are actually Dr. John Mew's patients, and he is actually quite famous in the orthotropic world. Orthotropics is a little bit different from orthodontics. It's all about stimulating the jaw to grow as it should, instead of just putting braces on the teeth and forcing the teeth to move where we want them to. And Dr. John Mew is very adamant about teaching his patients to close their mouths while they weren't talking or chewing or putting food into their mouths, rather. We do chew with our lips closed. That is important for face formation. But, and then he put them in these orthotropic appliances, and they both got the same care from the same doctor, same appliance, but Sam refused to learn to keep her lips closed and to keep her tongue to the roof of her mouth, whereas Kelly made sure that she kept her lips closed and kept her tongue to the roof of her mouth. And Sam is the two pictures up on top, age 8 and age 15 are her pictures up there. You can see the strain in her face, and that her face is longer than her sister's face. And that is because her jaw has opened, the angle has become longer. Instead of being more of a 90-degree angle, it is much wider than a 90-degree angle. And it's like, okay, who cares? She has a hard time keeping her lips together, and the jaw, angle is longer. Who cares? Well, it's a problem because that means that the jaw is actually not holding all of the structures in the mouth, mostly the tongue and the first part of the pharynx, out of the airway. When the jaw sits back, those structures are forced into the airway, closing off that airway. So that's why it's a big deal, because then it affects our breathing. So how can you find out if this might be causing a problem in your sleep? There are many things that cause problems for our sleep, and this is only one of them. But something that you can do is go see a dentist who has a CT scan. And a CT scan is a 3D X-ray that will allow that dentist to measure your airway. So that's the most effective way to find out about your airway. One way that you can do at home, though, that can give you some idea as to whether or not your face growth is growing the best way possible for your function, is to measure this. It's called the line. This is what this measurement is, and it's from the tip of the nose to the tip of the upper front teeth. And so I've got this little millimeter measurement marker here, and I'm just going to measure from here to the tip of my nose, and I'm getting about 45, and which is a little bit long. It is a little bit long. I, in fact, struggled from all of these things. It wasn't until I became an OMT that I learned about all of this. And so I'm doing physical therapy, orofacial myofunctional therapy on myself as well. And I had my tongue tie released, and we're going to talk a little bit about the benefits of that a little bit later. But anyway, this formula is really great because as a child's face is growing, we can do this measurement, and the formula is for males. The measurement should be equal to 23 millimeters plus the patient's age in years, and for females, it's 21 millimeters plus the patient's age in years. So if an 8-year-old, it would be 23 plus 8. And then if that measurement that we're actually getting is more than 5 millimeters greater than what it should be according to this formula, then we know that that patient is probably growing more long ways than they are forward and to the side. And so it might be an indication that they should see an orthodontist, an airway-focused orthodontist, or an airway-focused dentist, or a neuromuscular dentist, someone who's going to help stimulate that forward face growth. And an orofacial myofunctional therapist who will then neuromuscularly train that person to take on better habits so that they can continue that proper face growth and open up that airway so that person can breathe better. This is an amazing cephalograph of a person who came in to the dental office and they got this x-ray taken, and we can see that their airway is very narrow. Even if you didn't know anything about airway, you can tell the difference between these two airways. And so this is before treatment. And then after orthotropics and myofunctional therapy, this is what their airway looks like now, which is fantastic. And you can see that the formula here works, that the distance from the person's tip of their nose to the tip of their tooth is actually longer in the first x-ray than it is in the second x-ray. So as the upper jaw grows forward, that allows space for the lower jaw to grow forward. And the upper jaw will often trap the lower jaw and keep it back unless it is given the proper stimulation to grow forward. And so as the upper jaw grew forward in this person, that lower jaw was also able to move forward. And that works really well for kids. For adults, we need a little bit more help, and we'll get into that. I also love this graph, and I had to draw a little nose on these people, but you can see that this purple line, which is the line between the tip of the nose and the front tooth, is much shorter than the tip of the nose on this person and their front tooth, and the angle of their jaw here is longer. It is more obtuse, it's a more open angle, and this is a slightly more acute angle. It's more of a 90-degree angle. So this person's jaw that has the correct forward growth of their jaw is holding the tongue and the pharynx out, tongue out of the way and opening up that pharynx. The person who has the more obtuse, longer jaw, obtuse angle, that jaw is kind of shoving all of those structures back into the airway, closing that airway off. And so it's really, really important that we pay attention to the forward growth of our children's faces, and the width of our children's faces. As they grow longer, all of those structures get narrower and more closed off. Now, there's been a lot of talk about tongue ties. If you are in the tongue tie world, people are now all talking about tongue ties, but tongue tie is not the only thing that causes low tongue position. This right here is a CT scan of a person whose face, we took a CT scan and then we chopped that CT scan so that we could see just down the side of their face here. And so we can see the nasal concha, the turbinates, and this is a sinus right here, and this is a sinus that has some mucus in it or a cyst or something. And then this is the roof of the mouth, also the floor of the nose, and it is quite narrow. Ideally, it would be much more broad so that the tongue itself could just rest. The whole tongue itself would rest along that palate, but right now it's being squished down here, and the tongue is having a really hard time getting up into that palate. And so why is that happening? Well, it could be a tongue tie. The tongue tie is literally the ligament holding the tongue down off the roof of the mouth because it's too short. That's what tongue tie means. The ligament is too short, that frenum is too short. Everyone's got a frenum. Some of us have enough length in the frenum that our tongue can do what it needs to do, and it can go where it needs to go inside of our mouths. And some of us, that frenum is too short. And when that happens, it can cause this problem. But that's not the only reason that a tongue will sit low. In our society, we use a lot of bottles. We use a lot of straws. We use a lot of binkies, things like that. Children suck their thumb, and they've probably always sucked their thumb. But if they're doing that for a long enough period of time, then that tongue is going to train to sit low. If we're putting a baby bottle in the mouth and it's forcing the tongue to sit low, straws sometimes force the tongue to sit low. Thumbs, fingers, sucking on fingers often force the tongue to sit low, and the tongue will learn to sit low. in the mouth instead of filling the mouth. Ideally, the top of the tongue should touch the top of the mouth. The bottom of the tongue should touch the bottom of the mouth. The sides of the tongue should touch all the teeth. That tongue should be filling that space. And it's so important that it does that because the lips and the cheeks, like I said before, are putting pressure on the teeth. And it's its job to put pressure on the teeth that way so that the teeth stay in the mouth. If we didn't have lips and cheeks, our teeth would probably like flare out really funny because the tongue would be pushing on them from the other side and forcing them to flare out. So we need lips and cheeks to keep the teeth inside. We need the tongue to keep the pressure on the teeth so that the teeth form this nice arch around the tongue. And if it's not doing its job, then the lips and cheeks, they're going to put pressure on the teeth still. And then there's nothing to counteract that pressure, allowing for the jaw to stay really small, the teeth to get really crowded, and that's all due to a lack of either tongue muscle tone or poor tongue position. And so other things can cause this, and so it's definitely important to see a dentist who is airway focused and is looking at all this, looking at why the face is developing the way it is, looking at the teeth, why, if they're crowded, why are they crowded? Let's take care of it. Let's get to the root cause of this. So anyway, I've had a lot of people talk about how they need to release tongue ties. That's important if it's a tongue tie. If it's not a tongue tie, then we need to figure out what else it is. So where should your tongue sit? So the tongue should sit up at the roof of the mouth, like I said, and we call this little spot, this little incisus papilla, the spot. That's what I'm always telling my patients, to put their tongue while at rest. It just rests, the tip of the tongue rests right behind the two front teeth, and then the rest of the tongue follows behind it along the palate, putting that nice even pressure, gentle, very gentle pressure along those teeth. We're not forcing it up there with all of our strength. We're just allowing that tongue to fill the whole space. And so you can see this kind of side drawing here where the tongue is in fact filling that whole space. It's resting along the roof of the mouth. And of course it naturally kind of sits along the bottom of the mouth unless you're really forcing it to do something else. But anyway, with that even pressure, we should be seeing the teeth kind of come into place as we're chewing properly and swallowing properly and breathing properly. All of these things should allow this skull to form properly. There are 5 dimensions of tongue tie restriction, or not tongue tie restriction, tongue restriction, excuse me. Kotlow is just really quick, and you can skip this part if you want to, but if you want to know, here it is. The Kotlow free tongue measurement is how far can you stick your tongue out of your mouth. So if I've got my little millimeter measurement stick, I can stick it out 16 millimeters. Well, I'm good to go there, right? And then the TRMR tip is total range of motion, tongue to incisive papilla. So that's where you open your mouth all the way, and we're actually going to go into that. And then you'll measure that, and then you'll open your mouth, stick your tongue up, and then you measure that, and you divide one by the other, and you get a percentage. And then there's the lingual palatal suction, where you stick your tongue up to the roof of your mouth and you suction it, because this part is checking the back of the tongue. And then you measure, and then you divide that measurement by the maximum mouth opening. And that gives us a measurement for how well the back of the tongue can move and do what it needs to do. And then we need to check for floor of mouth compensations. What does that mean? Well, this is the floor of the mouth underneath the tongue, and it will oftentimes move with the tongue if the tongue needs it to. And so if we're swallowing and the tongue has a very short frenum, then the floor of the mouth will move up with it. And that means that tongue is really pulling on the floor of the mouth, and it's having to work extra hard in order to do what it needs to do, because it's pulling on more structures and creating a lot of tension in the jaw. And so the 5th one is tension. Are we seeing a lot of tension in the mouth, in the jaw, in the space right behind the mouth, the whole oral pharynx? And so a lot of these can cause restrictions of the tongue and prevent it from doing its job. And we need to look at each one in order to know how to help you. So this is the math for for Dr. Zaghi. He created this measurement to know whether or not the tongue mobility is causing some of the restrictions, that the ligament, it's the frenum underneath the tongue is causing those restrictions. And so you can see this person is opening as wide as they can, and she got 44 millimeters. And then she put the tongue to the incisive papilla, the spot, measured again, she gets 22 millimeters. The anterior portion of the tongue, or the first half part of the tongue, it should have a lot of mobility, right? And then on this other, on your lower left, we can see that the person is suctioning their tongue to the roof of their mouth and measuring again. She gets about 20 millimeters that time, which is pretty good. And so you can see that they're dividing the smaller numbers by the maximum amount opening and getting a percentage. And we're going to talk about the grading system. And here we go. Dr. Zaghi's functional classification for anterior ankyloglossia follows this classification system. Class 1 means that there's no tongue tie. It's got, that tongue has great mobility in the front half of their tongue. That tongue is reaching 80 to 100% of the maximum mouth opening. Class 2 means that the tongue reaches 50 to 79% of the maximum mouth opening. So they can't quite reach the top, but that person's like just short of 80% there. And so they have a slight tongue tie. Class 3, the tongue reaches 25 to 50% of the way up. So significantly less. That person has a moderate tongue tie. In fact, people who have a moderate tongue tie tend to be more prone to any of the complications that come with tongue ties and can be blamed on tongue ties than even severe. Class 4 is a severe tongue tie. It means that the tongue can reach less than 25% of the way up to the top of the mouth. You can see that this tongue is being held down by this frenum, and it's hardly going anywhere, and it's creating this what we call a heart shape in the tongue. And they actually tend to have fewer problems than those who have this moderate tongue tie. And so to be in between tends to put a person at worse risk of teeth issues specifically. Now, breathing issues, that may not be true, but for teeth issues like alignment of teeth and other things like that, having a moderate tongue tie really can throw the bite off and throw the teeth out of alignment more so than any other class, which is really kind of interesting. We're studying more and more about that. Dr. Zaghi is doing a phenomenal job on figuring all of that out. This is the this just talks a little bit about how hard tongues have to work. When they are tied down, you can see the floor of the mouth here as the person reaches their tongue higher and higher because they can't quite reach the roof of their mouth. And so this person put their gloved finger inside the mouth and held the floor of the mouth down where it should have been. And then the person tries to lift their tongue and they can't hardly lift their tongue at all, which means that person is working extra hard. Every time they swallow and their tongue is supposed to come up, they are pulling on the floor of their mouth and just really doing everything that they possibly can in order to swallow correctly every time they swallow. And we swallow our own saliva like 500 to 1,000 times a day, depending on who you ask. And then we swallow, liquids and drinks, and we swallow food. And so if the tongue is pulling on the floor of the mouth over and over and over again, that tongue is going to get tired and it's going to start creating bad habits. And we call those compensations. So and this is kind of a before and after drawing of what can happen with a tongue when it comes to myofunctional therapy. So if the tongue is sitting low, but maybe the top part of the tongue is sitting on the roof of the mouth, but the back part of the tongue is not. Well, this would be a drawing of what that tongue looks like, and all this space, this airspace that should be filled by the tongue, because we've got teeth on either side here, right, that need that support of that tongue, and it's not getting it. And so the back teeth are then moving in towards the mouth, or they've never moved out like they should have. And But then after myofunctional therapy, and if a person needs tongue tie surgery, then that tongue can then come all the way up to the roof of the mouth, supporting the entire inside of the mouth and have the mobility to do so. This right here these are Dr. Wong's patients. Dr. Wong is awesome. He's out in Australia, and he does orthotropics as well. And he does some exercises called GOPEX, which are good oral posture exercises, which are not the same thing as functional exercises. He believes more in posture than in neuromuscularly retraining the muscles, but they're kind of all the same thing in my opinion. I'm meaning that you should use a little bit of both. I definitely use a little bit of both for all of my patients because we all need to focus on our posture when we're standing and sitting, and that is going to help our overall tongue posture. If we have forward head posture, that actually holds our tongue down more than when we are standing straight up. And so it's important to work on posture. It is also important to work on the function and retraining the brain's neurons that connect to the tongue muscles and making sure that those are making correct habits so that we don't have to think about our swallowing all the time, right? We want to correct the swallowing, we want to correct the breathing, we want to correct the chewing, and then when we do, the face has an opportunity to grow correctly. So I love this picture. This person, it's actually kind of sad. This person had 3 tongue tie releases before they came to someone who understood that there's more than just tongue tie restrictions, that there are tongue space restrictions. This person, as you can see, their mouth closed maybe just a little bit to reach their tongue up to the roof of their mouth, but not much. So they're in that class 1 stage of mobility, right? They don't have a tongue tie anymore. He may have had a tongue tie at the very beginning, but he doesn't anymore. And but he couldn't get his tongue to sit on the roof of the mouth when his mouth was closed. And he kept complaining about this. He said, I've been to myofunctional therapy and I got my tongue tie released, and so he would go to different dentists and he would get it released again because he just couldn't get his tongue to sit like he was taught it was supposed to be sitting. But guess what? It's not a tongue tie restriction. It's a space restriction now. And people can often suffer from both, especially if they're getting into adulthood and their tongue has not been doing what it should have been doing this whole time. Well, now we don't need to release the tongue anymore. We need to get him into some kind of expansion appliance and help give the tongue the space it needs so that it can get out of the airway and fill that space and keep everything where it should be. So there are multiple types of tongue restrictions, and we need to pay attention to who's got what kind, and you need to find a doctor or dentist or a myofunctional therapist who understands that and can get you the treatment that you need for your mouth. So a couple of things on appliances. How do we do this? So for really little kids and even for adults who are trying to correct their swallow pattern, you can see that this person has what we call an open bite. She's got this, she's so adorable. Anyway, we can see that her back teeth are sitting together, but her front teeth are nowhere near each other. And that is because she has a tongue thrust pattern. And so if a person has a tongue thrust pattern of almost any kind, there are lateral tongue thrust patterns where the tongue is shooting out the side. There are forward tongue thrust patterns or an anterior tongue thrust where the person is shooting their tongue forward instead of the tongue coming up. The tongue should always come up when we swallow. It should not be shooting to the side or shooting forward. And so this person was struggling with that, and she's really little. And so they were having a hard time teaching her to correct that. And so they gave her the Froggy Mouth appliance. The Froggy Mouth was created by a French dentist. And he found that if he kept the lips open so that they couldn't try to engage in the swallow part of the face function, that the tongue would have to do more correct work on its own. And it's really quite cool. I've used this on several of my patients and I love the results. You can see on this third picture, the actor picture, that her teeth are almost all together now. And she and they're gonna let her grow some more and see if they need to do anything else as she forms, but they're gonna keep a close eye on her. But I love that as the lips are gently pushed out of the way, that they can't then try to help with the swallow, because that's a compensation that the lips try to do if the tongue isn't swallowing correctly. The lips will put extra pressure on the teeth in certain ways that are incorrect, and then we'll start to either see crowding or we'll see a flaring or different things like that. And this very simple appliance that a person wears for 15 minutes a day for anywhere from 3 to 6 months, depending how old the person is and how much correction they need. This will just unconsciously trigger the proper swallow pattern. And the studies on this are really cool. So you should go look up Froggy Mouth. It's pretty awesome. This person is a little bit older. And so the Froggy Mouth isn't necessarily great for this person. This is the ALF appliance work, alternative light force, and meaning alternative to regular orthodontics. And so it is putting some pressure on the upper jaw here, so that it can move forward the way it needs to. And then the lower jaw is allowed to shift forward. It's pretty amazing how this all works. Now, this person also used myofunctional therapy training, which is a neurological training of the brain and the muscles of the tongue, creating better habits so that the person is growing in a more functional way and forming better that way. And it's just really awesome. I think the alpha is so cool. Now, for adults, there are tons of appliances for adults who want to non-surgically open up their airway. There are surgical options as well. But if you want to go the non-surgical way, it's definitely significantly less significantly pain-free as compared to the surgical way. It does take longer. Sometimes it takes 1 year to 2 years, depending on what you want to happen and how much growth you want. But these appliances will get anywhere from 4 to 6 millimeters of expansion, and that's a lot. 4 to 6 millimeters doesn't seem like a lot, but in the mouth, that's a lot. We don't want inches of growth, right? We don't want our faces to become like double the size. We want millimeters of growth so that our tongue has a place to sit and it's out of the airway, and then our mouth can close correctly and the jaw can sit forward. And then we have this nice open airway so that we can breathe the way we're supposed to, so that we can sleep the way we're supposed to, so that we can function the way we're supposed to. Anyway, I love this stuff. It's amazing. But there's not just the DNA appliance, which is the day and night appliance, which is this one. There's also the mRNA, there's the homeo block. There's so many. There's so many that I don't even know all of them, because people are constantly creating their own and tweaking what needs to be done for their patients. And then they come up with this new appliance. So what you need to do, because the most important thing that you can do, is find a airway dentist that knows how to get the results that you want. That's the most important thing. The appliance doesn't matter as much as what knowledge the dentist has and the fact that they can work with you and look at your case and see what your habits are and the way your skull is formed, and give you the results that you need, and to be able to work with you that way. And so anyway, that's the greatest lesson that you can take from this, is to find someone who can look at what you've got going on and figure out how to help you form and function better. Because these appliances themselves are not the entire answer. It's the myofunctional therapy. It's maybe using a couple of different appliances. It depends on what's going on, right? What has been keeping you from forming the way your face should have formed so that your airway would be open? We got to figure out what caused that and go from there. So a couple of books, or actually a few books, here's 2 that are amazing, that can help you kind of understand more about what's going on. Breath is awesome. It's written by James Nestor. He's an investigative journalist, which means he did his homework. And I love it because he's not a doctor or a therapist, a breathing therapist or myofunctional therapist. He's just a layperson who had breathing issues of his own, thought it was totally normal until a doctor said, hey, you really ought to, get some breathing therapy. And he was like, I breathe every day, excuse me. Why do I need help breathing? And it wasn't until he decided that he was going to go on that journey and figure that out that he realized that he really was struggling with his breathing and it was affecting his daily life. And so he goes through expansion and all of these things, and you get to hear about life on the other side of that, which is so nice. He also has a few exercises, breathing exercises, that vary from just helping a person become more healthy to ones for athletes who want to like bring it to the next level, which is kind of fun. Then there's the Oxygen Advantage, which is a phenomenal book as well. It is written by a breathing therapist. Patrick McEwen is a breathing therapist who has traveled the world teaching people about the proper ways to breathe, how to focus on the breath, and what our breathing should do for us and how we can better know if we are breathing better. And it has lots of exercises in there that a person can do to kind of see how well they are breathing. And there's a couple of tests that he recommends you try and some things like that. It's just phenomenal. It's a really great book. These two books are really, really cool if you want to know the science behind it all. Tongue Tied by Dr. Baxter. I love this book because it's not just written by Dr. Baxter. It is written by several other people, as you can see on here. We've got speech therapists, we've got oral-facial myofunctional therapists, we've got dental hygienists who become oral-facial myofunctional therapists, we've got board-certified lactation consultants. Each of them wrote various chapters in this book, and they all give their opinion on how to deal with the tongue tie, which is so cool because everyone approaches it differently. And you've got to figure out how you're going to approach yours if you have one. And it's really important to know that everyone sees the same situation from a different perspective. And then you can work with, you can find the person that you think that will help you, and so I'm a dental hygienist who is also an oral facial myofunctional therapist. And so I see things from the jaw perspective, right? And so I want the jaw to grow the way it should. And so I think it's really important that the tongue be the support, as you heard, we talked for the last few minutes about this. This other book, Jaws, The Story of a Hidden Epidemic, is also awesome. It is really, really fantastic in that they talk about how the jaw grows and how a child, if they need expansion to help them catch up to where they ought to be, then we should start that pretty soon and not wait until the age of 12, because the age of 12 is, the face has almost entirely formed by the age of 12. And if you start at the age of 12, then there's a lot of catching up to do. And so it's actually really great to start as soon as a child can understand instructions. And there's even some things that people can do for their babies to help their bodies form properly. And that's really great to know too, that we have more control over how our bodies form than we think. It's not just all genetics. In fact, I hear that from a lot of orthodontists. They're like, oh, your jaw didn't form well because it's genetically that way. Your parents' jaws didn't form very well. They had crooked teeth, and they had to pull several teeth in order to get the rest of their teeth to even fit in their mouth because their mouth was so small. And it's not true. We are seeing that genetically our bodies don't change as fast as we've seen them in the last few hundred years. And it takes thousands of years for genetics to change and evolve. But we've seen jaw changes in just the last few hundred years, which means it is the environment that we're in that is changing our jaws. And that means that we have control over it. Hooray! Yay! I love it when I have control over something that I can do to change for the better, right? It means I don't have to blame my genetics. It means I can do something to change my life for the better. And that's what I love about this. So that is my little presentation about tongue restrictions. I will be sharing more about other breathing type things and other airway type things. And if you've got questions about specific things, you can always let me know in the comments below. And I hope this kind of helped you understand why this is all kind of complicated and why you're probably hearing about tongue ties and tongue restrictions and whether or not tongue ties exist. And there's just a lot out there that's changing the way we are thinking about how our bodies form and the best way to get the best formation of our bodies and the best way to get the best function of our bodies. And I love it because it means that we have more control than we thought we had over how we form and function. And that's cool. It just means we change some habits. And that's tough, but it's not impossible. It's impossible to change one's DNA. It is not impossible to change one's habits. And so hopefully that gives you some hope and lets you know that you can, in fact, change for the better so that you can live a happier, healthier life.